We are live. Sir, you're muted, please. Sir, you are muted.
Good morning, everybody, and welcome to this extremely interesting webinar on the pharmacological strategies for childhood myopia. As everybody is aware now, we have a lot of options available for managing childhood myopia, including a lot of advancements and development in the pharmacological management. And this webinar is aiming to put into perspective all the pharmacological options that we have. And I'll just introduce our speakers. Welcome. I'll be welcoming everybody, all our speakers and panelists. As our chairpersons and co-chairpersons will be joining us, Dr. Partha, Dr. Jeevan Tityal, Dr. Mohan Rajan, and Dr. Namrata. We'll introduce them and add them. I have my co-moderators, Dr. Santosh Nawar and Dr. Manoj Mathur, again, who will be shortly joining us. And I am Professor Rohit Saxena from RP Center, AIIMS, New Delhi. We have a really great and exciting session ahead. Looking forward to some top class speakers, Dr. Sumita Agarkar, who's from Shankar Nethralaya, Chennai, Dr. Siddharth Kesarwani from the JNR Children's Eye Care and Squint Clinic, Mumbai, Dr. Jitendra Jithani from the Baroda Clinic, Children's Eye Care, Vadodara, Dr. Rebecca Dhiman from RP Center, New Delhi, and Dr. Jaspreet Sukhija from PGI, Chandigarh. These are our eminent speakers, and we have an extremely interesting and a great panel with us who will be discussing once we are through with all the talks. I think we'll go on to the main session. We'll start with Dr. Sumita Agarkar on the need for intervention. So I'll invite Dr. Sumita to please share her slides on the need to really intervene in children with myopia. Sumita, you're on mute.
So, good morning, everyone. I hope everybody can hear me.
Yes, sure. Slides are
Okay.
visible.
So I'm just going to set the scene here about the need to intervene, because a lot of us now know that myopia is a little bit more than just a pair of spectacles. So there is a need for tackling it a little bit more than just looking at the child and giving the prescription. So the definitions which probably will be used throughout in this webinar would be what myopia is: any refractive error which is equivalent or more than minus 0.5 diopter. And generally, for purposes of clarity, we define high myopia of error of anything which is minus 6 diopter or more. And I'm also going to define pre-myopia here, although there is not consensus on this, but probably any refractive error in a child of less than 1 diopter can be considered as pre-myopes. So these terms will be used throughout in the webinar, so I'm just making it clear here. So now, if you look at the need for intervention, we have to look at it in two terms, two perspectives. One is prevalence, and also its impact in terms of morbidity and socioeconomic burden which it causes. So if you look at the prevalence, this is a chart of looking at projections where it is going to go in from now to 2050. So if you look at Southeast Asia, where India comes, so it is projected to peak somewhere around between 60 and between 50 and 60% here. That's where we are expected to be in 2050. So this is a scary chart, and this is a global, depending on which area you are, everything is going to more or less increase beyond 50%, if you can see. So there is, to put it simply, now at this point, myopia is somewhere around 22.9% globally. and high myopia is around 2.7%, and it is estimated to be 49.8%. Again, these are projections and things may change, and high myopia is likely to be touching 9.8 to 10% globally. In terms of global population, 10% looks very less, but if you look at the actual numbers, it is a huge, huge number. Other worrying trends, which are probably worrying epidemiologists more than the clinician, is increasingly early onset. And what that early onset means is that it leaves more time to progress, and younger children also tend to progress faster than the older children. So increasingly early onset is definitely something we should worry. Again, high myopia prevalence has also increased disproportionately compared to normal increase in myopia prevalence. And that is also worrying because high myopia is associated with a lot more morbidity in later lives, which are which are more productive years of somebody's life. And a disproportionate increase in high myopia is also a little bit of a concern. So looking at the prevalence in India, I'm going to use 2 or 3 studies here, one based in North India and one is South India, and something which looked at country as a whole. So if you look at the staying alone in prevalence as to what is happening in our country, so North India myopia study was done by Dr. Saxena and his group, and it is a cross-sectional study and screened children for subnormal vision in 2 districts of Delhi. They screened almost 10,000 children from both government and private schools, and prevalence was higher in private schools versus government schools, as you can see, 17 versus 8, and in girls 14.5% versus 12.4%, and this is significantly higher than what was reported in the earlier studies, which was around 6% in urban and 3% in the rural children. So this in 2015 we have it was already touching 17%, threefold increase from what was reported earlier. One other thing which this study found was that only around 25% children were actually wearing their appropriate correction. They have also reported their data in a second study, which was done in predominantly rural children. Number of children were less in this study, but again, you can see if you look at historical data of 3%, prevalence was 6.4%. I'm just trying to justify why we need to worry about myopia because everything is jumping. This has come from South India and from our institute. So it's again, Shankar Netralaya, Tamil Nadu, Essilor myopia study. Again, this was a prospective longitudinal study, involved almost 14,000 children from 2 districts of Tamil Nadu. Again, we here screened both urban and suburban school children. We did not really go to the village, but the districts where one was Chennai and other was Tiruvallur, which is a district which is close to Chennai, but is on the slightly Mufassal area. We found no gender predilection compared to what was reported by Dr. Saxena. Again, myopia prevalence was 17.5% and prevalence was almost matching to what Dr. Saxena and his group found. Urban schools more, suburban schools also compared to less. And again, we also looked at the prevalence of high myopia, and that was touching around 3% in our children. So if you look at Orbis data, which also looked at screened children for refractive errors in this study, which is a large cross-sectional study in 5 states. In that study, we almost screened 2.2 million children between age 5 and 15, and prevalence of myopia was 1.57% in 5 to 9-year-olds, but it jumps to almost double by 10 to 14 and almost becomes 3 times by the time children are 15 to 18. So this is an all India study. Lots of children were rural in this study. So luckily, projections look slightly better for rural children, and it was a population-based study. So we went and we had two centers in north, 2 centers in north, 1 in east, and 2 in south in this. So in this case, again, myopia was associated with older age. Girls were more affected, urban locations, private schools more, and also by state. So because we had a way to look at these data state-wise, And the authors in this study felt that prevalence was not only driven by the state, but also by literacy rate, because myopia was found much higher in Tamil Nadu and Kerala compared to Madhya Pradesh and uh, West Bengal, which were also part of this data. So whichever data you want to look at, there is very clear evidence that there is a number of we feel that it is really way far. 50% looks a little more, but I think there is all this data in last 5 years has proven that we are on the rising trend. There has been an additional upheaval in the world after that, and COVID has really March 24th was this when schools went down into online mode for almost a year or longer for younger children. And again, we can see there was a big lifestyle change which COVID induced. Outdoor activities went down drastically during COVID time. Screen time went up for 8.5 to 19.8 hours. And of course, this change was again noted fairly more in boys and in students who were in private schools, probably because of better access to the online devices. Impact of COVID in our country has to be fully computed, but a small study by Krishnamurthy et al. In their data from public schools from September 2021 again showed a little higher uptick in the prevalence to almost 19.5%. If we look at our own data of pre-COVID, which was around 17, there was definitely an increase. And if you look at the same school, when they screened the same schools, there was almost a 3 to 4-fold increase in prevalence in the same cohort, which has been reported earlier. So COVID has changed the way our children study, and COVID has also effect of COVID still needs to be measured a little bit on more real life. So if you look at the second part of my talk, which was the impact of myopia, let's forget the increasing prevalence. Okay, numbers are going up. That is something worrying and we need to look at it, but also what myopia does. So it definitely has an effect on ocular morbidity. It changes the quality of life and it imposes a huge socioeconomic burden on health systems of the countries. And in our country, which is anyway resource starved, this is a burden which you need to compute far more pragmatically. So from purely ocular perspective, myopia is strongly linked to retinal detachment, myopic macular degeneration, cataracts, early cataracts, primary open-angle glaucoma, all of which are vision threatening. I would also add a small corollary to that, that complications related to contact lenses and refractive surgery also can be blamed indirectly to the myopia. All of them are severely visual threatening conditions and can affect not just can not only increase the burden of the healthcare systems, but also look at, even if you reported indication is myopic macular degeneration, but if you put 2% in the perspective of India's population, you can imagine the numbers and number of retinal surgeons and the resources which you have available for our country. You can see risk of all these conditions increases with magnitude of myopia and age. These are pictures from 3 kids and who are in their late teens, and you can see the already myopia has started impacting their visual outcomes, their visual quality in many ways. There are multiple lattices here, and this is a risk factor for retinal detachment later in life. There is early macular degeneration here and a cataract. You can see these are all children. They are from my patients. They are not really adults, but you can see where the things are going in another 20 years when they will be adults in their peak productive years. Is there a safe myopia? No, unfortunately, no. At as low levels at -1 to -3, you can see then they are more 2 times more likely to develop cataract, 3 times more likely to retinal detachment, 2 times more likely to develop macular degeneration compared to non-myopes. And you can see here the impact it has on the ocular morbidity as the myopia increases. So it is not for vain that we say every diopter matters, and why we should probably look at interventions which help the patient to stay within this range and prevent them from going here. If you look at the quality of life, myopia specific PROM questionnaires, patient related outcome measures questionnaires are imperfect because they are a little older and a little inflexible. But despite these limitations, several myopia related questionnaires have proven significant impact on quality of life in children or adults who have myopia. Results may vary from demographic groups and populations. Like in Western population, you may see inability to drive as a bigger impact on quality of life. But in India, it may be just going to the doctor for an elderly person and getting the prescription itself can be impact on the quality of life. So results may vary, but whatever result you look at, you can see that it has a great impact on the quality of life. Higher myopia has higher quality of life concerns like more expensive glasses in younger children or cosmetic concerns, while as loss of vision and loss of having complication has higher QOL concerns in the older children or older adults. Yokoi et al. Have actually reported 25% patients with high myopia are likely to have anxiety and depression issues. Older individuals who have macular degeneration have poorer vision related quality of life and definitely impacts their ability to move and lead independent lives, which is going to impact their quality of life. Impact on education, I'm here mostly on uncorrected errors, which can have definitely, which needless to say, that if they are uncorrected, it impacts their attention, performance, and ability to participate in school activities. But corrected errors, probably not so much, because it is a little bit of a dilemma here, because corrected errors increase their cost of burden in terms of cost, but also the benefits which are associated by that increased cost probably offset this. If you look at the economic impact, we have really no data available for our country here. If I looked at the thing, and if anybody has some data, I would be interested to know. But Singapore data estimates around $755 annually for direct costs. Direct cost means in terms of giving prescriptions, eye doctor visits, and surgeries. And it is much higher compared to other chronic diseases, say like COPD, 9 million. But also, we have to remember that Singapore has almost 80% or more patients who are myopic. So higher costs probably are compared to, say, COPD, are probably explained a little bit on that. But you can see the difference between 755 versus 9 million. Global costs in myopia, if you estimate, again, these are projections, almost $357 billion a year, and are expected to rise to $875 billion in 2050. I can't even fathom the number of zeros which is required in 870 billion, but you can look at the cost, which is, and this is only correcting the direct cost, means costs of providing the healthcare, the prescription, and to take care of the morbidities which are associated with myopia. But there is an additional hidden cost here in the terms of loss of productivity, which is 94.5 billion, which is expected to rise to 220, astounding amount of 223 billion in 2050. And this is a hidden cost. We don't calculate it when they're. A lot of these patients who are highly myopic or who are moderate myopes, they are likely to have the comorbidities in their most productive years of their life. So this needs to be computed for our country. And also we can look at the amount of burden it is going to place on our healthcare systems, which are anyway resource starved to start with. So we need to look at myopia from this perspective also. So costs of myopia definitely are going to myopia interventions, which we are going to discuss today and which are available, are definitely likely they are going to increase the direct health expenditures in the early years when our target population is children. But benefits of increased productivity and decreased morbidity, which is going to follow with higher myopia, make this increase worthwhile. And I think it is not something which we should grudge about adding the cost. Will this pan out the way we envision it? We have to wait till 2050 to see whether today's interventions are going to change the ocular morbidity pattern or prevalence pattern in coming years. Whether these interventions have been successful, only time will tell. Thank you very much for your attention.
Thank you very much, Sumita. That was beautifully put. I'm really glad you gave numbers which actually matter to us policymakers world over, which is in dollar terms. So when we talk 100 million children or 5% or 10%, it's sometimes very difficult to give the real perspective of what we are talking about. And when you're putting this that loss of productivity, the costs are coming to in 100 billions and more. Uh, I think it is something that I'm sure will impact and will push governments all over the world to put the money where it matters, which would be in preventing, how to prevent children from becoming myope. So I think we'll go on to the next one, risk factors, before we have a brief discussion and then follow up with the meat of the talk on drugs. So pleasure absolutely to invite Dr. Siddharth Kesarwani, who will be talking about understanding risk factors and their modifications. And always a pleasure to listen to Siddharth.
Good morning, everyone, and thank you, Rohit, for that very generous introduction. I would just like to add to what Dr. Sumita said. The burden in the society is seen all around us. We have many more children in our own families with myopia, in their classrooms with myopia, and in our clinics with myopia. So it's there everywhere for us to see. So I'll be speaking about lifestyle interventions to prevent myopia progression, because that is one thing that will probably not cost money to do, and it is something that will have a much larger impact than trying to treat it with glasses or drops. So if you make these lifestyle modifications and you do some interventions at the policy level, at the education level, then the overall burden impact will be much less than the individual interventions that we do. So the increase in myopia has coincided with changing life, period. Now, everything has changed in our children's life as compared to our lives, and which was much more different from our parents' life. So if a particular disease shows an uptrend, then you have to look at each and every aspect of changes in lifestyle rather than looking and choosing which lifestyle would have probably affected. So what has changed? More and more people are living in urban spaces, in limited open spaces. They have reduced access to natural light. There is increasing academic pressure in competition. There is excessive academics. The early schooling, the syllabus has just for small children has gone through the roof. And the digital devices have become commonplace with cheap data and increased schooling through digital devices after COVID. The families have become smaller. Usually the single child families are there and they don't have many peers to interact with. And the food habits have changed. There is increased processing, preservatives used in the foods that we eat, less access to fresh and seasonal fruits. The air is polluted. And to summarize, other than communication and health, medical field, we seem to be going backwards in everything else, be it food, water, clothing, shelter, meaningful education, and even moral values. So, when a particular disease in children is coinciding with their cross change in lifestyle, we need to look at each and every aspect. Now, once we come to lifestyle modification, the commonest thing is okay, play outdoors and don't study. I mean, that is the thing that we focus on, and we never really talk about the other risk factors that may be contributing. So I will talk in the other way around. I will talk about the lesser studied factors and leave the more studied factors till the end to show that even small things that you and I don't think of may be contributing to the increased incidence of myopia. So this is a similar study of the way I told you. It's a relationship between the family structure and myopes. So this study showed that nuclear families, the children in nuclear families, they are at a higher risk of getting myope as compared to children with extended families. And they are even at a higher risk of getting myope and children who live with their grandparents. So the family structure may be having a role to play. This another, meta-analysis of studies showed that the firstborn child in families is at a higher risk of developing myopia. And he may be the only child, or he may be the first child of 2 children or 3 children or 4 children. That doesn't matter. What matters is if he's the firstborn child, then he is at a higher risk of developing myopia. Uh, the other thing that parents usually ask after the diagnosis of myopia is what are they doing wrong with their child's nutrition, whether they can give something to eat. And usually we tell them that, look, food has nothing to do with myopia. That is not entirely true. I think food has not been studied to that great extent or in that great detail, or each portion or each subtype of food has not been studied in that great detail for us to localize on the deficiency or excess of something. What we have is the outcomes of certain studies which have sometimes contradicted each other. But what grossly we can suggest to parents who ask about dietary advice is that you reduce the intake of carbohydrates, you increase the consumption of proteins, and you reduce the intake of sodium, and you give fat in moderate quantities, and you give things that have good amount of omega-3 fatty acids. But there are no particular food groups that you can, say that, okay, this particular thing is very important and this is what you should include. Grossly, what goes for diabetes also goes for myopia, that you have to reduce sugar and salt and carbohydrates, whereas you have to increase protein intake and you have to have a moderate fat in your diet. The increased consumption of whole grains was also found to have a protective effect on myopia. It was also demonstrated that newborns who are breastfed with where breastfeeding is more prevalent, have a lower incidence of developing myopia as they grow older. So nutrition does have a role. It's just not very clearly defined. These days, obesity is also on the rise in children, and it also has been shown to have some kind of association with myopia. So obese children, especially girls, are at a much higher risk of developing myopia, and probably insulin resistance has got something to do with it. If you are obese, you are more insulin resistant, and then your body secretes more insulin. That leads to trigger of insulin-like growth factor, which ultimately contributes to increase in axial length. So obesity also, which is also a type of malnourishment, is also linked to myopia. So because children are becoming more and more obese. In a nutshell, increase in sugar, potassium, sodium, carbohydrates, and cholesterol have been shown to be associated with increased incidence of myopia, whereas gallic acid and animal proteins and lutein and resveratrol and vitamin C and D and PUFA, which is polyunsaturated fatty acids, have been shown to be protective against myopia. So specifically, fruits like grapes and blueberry and gooseberry and banana, papaya, citrus fruits like orange and mosambi, you can suggest the parents to give more to their children, give them green leafy vegetables, and also give them a portion of nuts, seeds, and also try to sprinkle saffron once in a while. Uh, these children are sleeping late. They have to get up early for school, and they have too much homework, or they are on their devices till late night. So does sleep have an effect? Because sleep has also changed over this generation. So there are contradictory reports. Few reports say yes, sleep and myopia are directly correlated. The more you sleep, the less you have myopia. While other studies have failed to find a correlation. But failing to find a correlation doesn't mean the absence of correlation. It may be a part, because the study doesn't specifically look into it, and it is only a part of many other factors they look into it, and it may not be adequately powered to look at sleep as a factor. So if you have sizable number of studies that show that, sleeping well is important, then it should be a factor. And probably when you do studies which target sleep specifically, then you might get a more definitive answer of how many hours of day that a child should sleep. Currently, you can safely say that if a child sleeps more than 9 hours in a day, then they have a much lesser risk of myopia than children who sleep less than 7 hours in a day. Children are getting less and less exercise, and does that have a role to play? As I said, lifestyle means everything. Whatever you do, what you eat, how you sleep, whether you exercise or not. So till date, physical exercise has not been, conclusively shown to be independently affecting the outcomes in myopia. Most people say the studies that show that physical activity changes the risk of myopia are actually because of outdoor activities. But there are studies which have specifically studied this, and they have showed that children who play badminton and table tennis, now these are indoor activities, but still because it involves looking at near and far in quick succession, some kind of a flipper activity, they tend to have lesser myopia. So there may be something to look at. What kind of sports do you study to children? If you probably certain sports are better in controlling myopia than other sports. We are living in more and more pollution in cities, especially air pollutants, because water you can purify, but most of the time the air you breathe you cannot purify because it's there everywhere. And it has been shown that carbon monoxide, nitric oxide, uh, do reduce the retinal dopamine secretion, and because of oxidative stress can cause resultant myopia. Particulate matter has also been found to be directly associated with increased myopia in children. Now, all associations are not causal in nature. You have to understand that if two things are simultaneously increasing in a society, then you will find an association. The pollution is increasing and myopia is increasing, you will find an association. But whether pollution exactly causes myopia or not depends on the biological plausibility. In this case, there is a biological plausibility that the oxidative stress in pollutants may be responsible to alter ocular health. Passive smoking has been conclusively shown to increase incidence of myopia, especially if the passive smoker is smoking very close vicinity of the child, like in a car or in a room. Does housing have an effect on myopia? Like moving into urban environments actually changes the way you live, in the kind of houses you live, in the size of houses you live, in the floors you live. So that has also been studied. In Australia, it was found that confined housing types and apartments, the children who live in those had a higher risk of myopia than children who lived in standalone or separate houses. That was in Australia. In China, they found that in multi-storied building, the children who live, they have a higher incidence of myopia than children who live in flat rooms or standalone houses. So yes, the housing also makes a difference. These days, children are exposed to much more stress than us, may it be academic stress or, competitive stress. So whether that contributes to myopia, because many times you might have, a person has two children and one has myopia, other doesn't have myopia. Is there a baseline personality difference between the child that results in myopia? Whether that is the cause? Well, that has also been studied, but not in great detail. And then they found that children who were exposed to more stress and sometimes abuse and fear as very young children showed a higher incidence of myopia. Now we come to the more commonly talked things like near work and myopia. Well, near again, if you look at the meta-analysis, near work does affect myopia, but doesn't affect myopia to the extent that we propose it to be. So odds of myopia increases by 2% for every 1 diopter hour more of near work per week. So you really have to do excessive near work for it to affect the outcomes in the end. So sometimes it is said that near work is actually a surrogate for not going outdoors, and it is the lack of outdoor activity that is more important than near work. But albeit all the studies do show that there is a small contribution of near work, especially the working distance. So if the working distance is less, for 1 hour of reading, you are using more diopter hours. So you require more diopters to do near work if you are reading at a closer distance. So that can actually affect the outcomes. Excess schooling. So these days there is a trend of parents sending their children to school even as early as 1.5 years of age. Something called as Montessori came up. Earlier there was junior KG, senior KG, and then there was nursery, and then there was playgroup and nursery. Now there is Montessori playgroup and nursery. The number of years that the child spends in school is slowly increasing. And studies have shown that it's the grade and not the age that increases the risk of myopia. So if two children of the same age, one in a higher grade and one in a lower grade, the higher grade child is at a higher risk of myopia because by the virtue of having spent more years in school. In another study, they showed that 4 hours per day of near work in tutorial classes. So, after school tutorial classes are one of the risk factors for developing myopia. And if your tutorial classes are going to 3-4 hours every day, you are almost 120% more likely to develop myopia. This is very interesting. Because reading also involves reading from a book, and the book is usually white background, black text. So a study was done to find out whether white background and black text is worse than a black background and white text. So they found that yes, if you are reading text on a white background, it has a higher, you end up with a higher risk of myopia because the blood flow to that choroid becomes less. So the choroid thins out, and it's been shown in animal studies that thin choroid is directly related to increase in myopia. So it would be better if in future you have textbooks with black pages and white print on it. These are studies which are telling us to study these factors which have not been studied so frequently but may hold the key. Or maybe near work is not that bad, but looking at the print, white, black print in white background may be the real culprit. Outdoor, how much is protective? So when you tell a parent, send your child outdoors, now he has to figure out how much is protective, because he wants to send bare minimum. Because two things, his schedule, the child's schedule is packed and it is not very safe outdoors these days. So Chen et al. Found that at least 15 minutes, only when you spend more than 15 minutes in an intensity of more than 2000 lux, that is where the protective effect starts. Lesser time, it doesn't help. And if you are spending time in a lesser, bright area, then it is also not protective. There were studies which were done that introducing 40 minutes of outdoor time in children in school in China and in 80 minutes of outdoor time of school in Taiwan, they were protective as far as the incidence of myopia was concerned. So yes, outdoor, the total amount of time spent outdoors is a factor, and the brighter the light, the better it is. And bright means it doesn't have to be bright outlight in the sun. Even playing outdoor in the shade under street lights. Street lights are also quite bright. That is also good enough. If you are not sure about the lighting conditions in your building, then you can use these apps which are available on smartphones, which can detect the level of lighting, and you can give the corner of your house which is brighter to the child to study, and you can check out which part of the building is better lit where he can play. And those small things can, if you guide your patients, they can, help the child more effectively rather than making a blanket statement, send them outdoors. Now, this also showed that for every hour increase in outdoor play, then it reduces the risk of myopia by 2%. Now, this is a very interesting study recently done, not only bright light, it showed that exposure to very dim light, that means darkness, is also protective against myopia. That is very interesting because these days you feel that, okay, the child is not getting enough bright light, but the child is not also getting enough dim light. Their environment is mostly ambiently lit, the school environment and the house environment. And at night also people sleep with the night lamp on. So what is also important probably is that both the extremes of light are missing in the child's environment. So even dim light may have a protective role to play. So maybe you should not have night lamps in the place where the child sleeps so that, it is completely dark. Maybe this constant stimulation of the retina is also not good. Screen time is often blamed for everything. Yes, there is certain amount of truth in that. A daily 1 hour increment in digital screen time. Digital screen time includes even television, which is far away. increases the association with myopia by 21% higher risk of myopia in those children. And the France has already banned devices in school, and American Ministry of Education says that the school gadget time should not increase more than 20 minutes per day. So yes, reducing screen time is important, but exactly how much of screen time is protective is not yet known. But in meta-analysis tells us that probably 1 hour of screen time in a day should be okay, because the detrimental effect only starts after you exceed 1 hour of screen time. So in recommendations, if you have to give to parents that, physical activity, if you can add 1 hour per day to a child, it will reduce his risk of myopia by 12%. Each additional hour of screen time reduction can reduce the risk by 31%. Among children and adolescents, 1.5 to 2.5 hours of near work increased the risk of myopia by 25 to 29% respectively. So if you can reduce near work also, it can reduce the incidence of myopia by 24%. So if you can make all these, you need not do, extremes of something. If you do a little bit of everything, it will all add up to a sizable percentage of reduction in the risk. So these are all the factors that are implicated and they are being studied. What in the end, I would like to conclude that lifestyle may hold the key to effective management of myopia. No matter how many glasses and drops you put, unless you change the lifestyle, these therapies may also not show their exact benefit. It's necessary to look in more details into each lifestyle issue. So every particular risk factor has to be studied in a randomized control trial in a quantitative way in order to come up with recommendations. There are many overlapping risk factors which are, contaminating each other's results, and that's why causality needs to be established in most of these risk factors. And recommendations ultimately at the policy level, at our level, are needed to crystallize so that it doesn't grossly affect a child's lifestyle. You can't tell him to, start behaving like Mowgli and, go into the jungle and play in the forest and not do anything just to prevent myopia. So we have to become more specific as far as what has to be done during lifestyle modification. Thank you very much.
Thank you, Siddharth. And as I had promised everybody, Siddharth's talk is going to be an absolutely refreshing take on lifestyle modifications. Nothing was, the whole talk was highly unpredictable. And that's why I was happy to give Siddharth a topic which was not to his liking, but I really enjoyed it. Thank you, Siddharth. It was an absolutely refreshing take. So,
Thank you.
like I said, before we go on to the meat of, these sessions that we want to talk about, we could have a few words in about the two things we have discussed about the magnitude of myopia and the lifestyle modification. So maybe we'll take it quickly. People can raise their hands. Let me see. We'll start with Vivek, Ramesh, Love. So in that order, we can start. And anybody else wants to chip in, we'll can just raise their hands and we'll just have about 5-10 minutes of discussion. So just raise hands, be brief. Or anybody else wants to start? Yes, Ramesh.
Yeah, I think I agree, Rohit. Both talks were excellent. It gave a different perspective most of the times we don't understand. I just wanted to give a perspective about the rising myopia in India. I think it's still there is a divide between the population-based study and the hospital or the school-based study. In the school-based, especially in the urban, we are almost reaching 20%. But in a population-based, compared to other countries, probably East Asian countries, we are doing better. That's the positive aspect of it. But school-based, it's pretty high. 1 in 5 children is, I think it's already high. It may not be as high as Singapore or Taiwan, where it is touching 80% or 90%. That's why the population-based, any policy or anything in India is slow because we still have that. But if you don't take care of it, we will reach 20%, 30%, 40% very, very fast. So I just wanted to highlight that. Otherwise, if you don't take it, if you don't make any policy change, because India does not have a myopia prevention policy change. So that's number one, I felt. And number two, Siddharth, you said everything. I think nutrition to outdoor activities and near work to everything. One more thing is that people ask, can the child read a book or a screen? I think both of them are equal. Especially one factor we check in all the children is some of the children lie down and read. In them, it's even more closer. So that aspect also, I think we have to ask, because most of us ask screen time, but even the near work matters. Either black and white, people are going into the micro granules of black and white book or a font, all that. And people are even looking at, is the screen better, iPad is better, or a laptop is better, or a TV is better. So there are a lot of unanswered questions, but I think I enjoyed both the talks. Thank you so much.
Parikshit, yeah, comment on the dichotomy what Ramesh is pointing out between the school-based and the community-based surveys.
We definitely need a permit.
But I think we've lost you, Parikshit. Could you a little better? Yeah.
I think both the talks were fantastic, and what Dr. Siddharth said was something very new and very, very different. But what Ramesh was saying is perhaps we are not there where East Asia is today. In many ways, we are. If we look at their per capita, so if you look at the top schools or the schools for the rich in Delhi or Mumbai or any other metro, their myopia prevalence levels are way, way higher. The study that was done, a lot of it was rural, and even in them, Tamil Nadu and Maharashtra had a much greater prevalence than West Bengal. So as our literacy levels will rise, as our per capita incomes will rise, myopia is going to get way, way more common. And I think what we've all set out to do, what we have all set out to do is very important. And we need to have some concrete guidelines other than just eye drops and outdoor activity. So thank you for getting this all together.
Thank you. Yes, Dr. Madhav, please.
Yeah, I have the same question what Ramesh has said regarding because 100% parents keep asking us whether the screen devices are better. And in that case, the mobile phone is better or the laptop is better. I think I have no answer on that, but has anyone specifically has any study saying that anyway, actually, is there any difference between the print media and the electronic media usage? Siddharth can give us some highlight about it.
Yes, there have been studies looking into both, and screen time has been an independent risk factor other than near work. So that has been studied. There have been studies where screen time has been specifically been blamed for myopia. So currently, what you can say is screen time in pecking order is worse than reading from a book. Worse than reading from a book, provided the book has got a font which is big enough and the book is kept at a reading distance of 33 centimeters. These days, because children are reading very early and children have small arms, their arms are not very big, they have small arms. So the reading distance is much less than our reading distance. So if that can be modified, then reading per se is from a book is better than reading from a screen. And that has been shown in studies. They have been studied separately.
I have at my place started saying that if you are reading on the screen, at least keep a light on while you are using the screen, because most of the time children have got that habit. It's in the evening time. They don't keep on the other room lights on.
Right.
So that I have started telling. I have yet to come across because it is about a year or
Actually,
so.
true. Yeah, ambient illumination should be high, and next to a window if possible. And as Siddharth pointed out, on a table chair, so that you can maintain the distance when you're lying down. Ramesh was also saying you bring objects very close to the eyes, and that becomes automatically a major issue. Maybe we'll come back because these are unending questions and discussions. Maybe we'll come back after the presentations. I think Jitendra was not able to join us. He sent a recorded video, and let's go through the pharmacological interventions and then maybe comprehensively discuss prevention and management. So we'll have the presentation by Dr. Jitendra on point 0.01 the current panacea for myopia? I think we're not getting audio.
We have to connect whichever laptop it is playing. The internal audio has to be played.
Yeah. Could you please, admin, could you ensure that we get the
The audio is not coming?
No.
the audio is not there?
To thank Dr. Rohit sir for taking interest in arranging this particular webinar on atropine. So currently we just had 0.01% atropine, and that was the panacea for all our myopic patients. To begin with, we should first understand that atropine in various concentrations has been studied almost in last 50-60 years, and starting from 1966 to 1973, multiple literature, multiple articles, multiple RCTs were done. So what was not understood was that how it works, but the fact that it works was well known, and multiple theories floating around, with some theories talking about which is the mainly accepted theory, is that it releases dopamine at the level of retina, and dopamine regulates the ocular growth. Then there are theories that it works on the fibroblasts in the sclera, and also it reduces the extracellular matrix production by decreasing the GAG synthesis in sclera. Now there is some interest which is in choroid, where they have suggested that it is actually the choroid, and it is thin in myopic eyes. That is well known, and it is the changes. So choroidal thickness is quite dynamic, and it is the changes in choroidal thickness initially which predicts or precedes the long-term changes in the axial eye growth. So the point or the theory is that the choroid starts thinning out early, and that is what gives way to retina to move further, and finally the axial length grows. So at this point of time, it's not really clear what is working, but beyond accommodation, whether it is the dopamine receptors, whether it is alpha 2 adrenergic receptors, GABA receptors, but the whole gamut of theories do talk about the fact that atropine does work, even with unclear mechanism of action. Now, there is some interest in last couple of years on the effect of atropine on lens thickness and power, with Dr. Rohit sir's article saying that a small change was noticed, and a similar article was published where they said that 0.01% did not make a change, but yes, a higher dose of 0.1% loading dose did make a change of 0.2 millimeters by Havid Hansen. So whether it makes a difference in whether it is really the lens thickness and power, which is also another alternate mechanism of action, or it is partly working for atropine, we are not clear. But there are still few things which are completely unanswered regarding whether it is just the muscarinic receptors, or it also inhibits retinal signals to sclera, which may come from defocus. The most important point is whether there are any long-term side effects or not. Whether with regards to delivery system, there is not much clarity. So it all started, at least this particular time, the whole thing started with Atom 1, published in 2006, where they proved by an RCT that atropine 1% works. And then they did a follow-up study published in 2012, 2013. Another work was published from Atom Group. They had 400 myopic children, and they basically concluded saying that atropine 0.5%, 0.1%, and 0.01%, all of them did show efficacy in slowing down the myopia progression. The placebo group was not there in this particular study because they used the placebo group of Atom 1, and to their surprise, 0.01% also worked very well. Although they did say that it was dose dependent, but they felt that the dose dependence was not clinically significant, and they did use 1 year washout period where they tried to assess the rebound. They did felt that rebound was indeed dose dependent. Also, it depended on younger children and higher baseline myopia, which showed a higher rebound. Now, the reduced side effects were obviously with the lowest possible concentration, which was 0.01% in ATOM 2 study. And now coming to a corollary of this, which was published a year back, Atlas study, where they tried to see these patients which were seen way back in 2010, or the ATOM study 2005, 2006, and they tried to follow them up over a period of 10 to 20 years later, and they felt that atropine did work actively during that time when the atropine was being used, but the final adult refractive error or the incidence of myopic complication really did not make much of a difference, although the sample size was not complete, not full. But it also highlights the importance of longer treatment. So typically there are a lot of questions that how long to continue low concentration atropine. So this particular study also highlights the fact that we may have to restart the treatment, and we will see similar recommendations by LAMP phase 4 trials. So this was LAMP 1, which was published in 2019, and what they did was the first study, ATOM 1, talked about 1%, and ATOM 2 talked about 0.5%, which is half of 1%, and 0.1%, which is 1/10 dilution, and then 0.01%. And now that in 2012, 2013, the stage was set that 0.01% is working very good. LAMP study, what they did was they broke the concentration further. They compared 0.01%, 0.025, and 0.05%. And in 2019, they published their phase 1 report where they suggested that 0.05% was better than 0.01%. And in phase 2, basically they compared the results of 0.01% with placebo in phase 1 and felt that 0.01 was clinically better than placebo, but not statistically. And in phase 2, they started putting the placebo patients of phase 1 to 0.05%, and they felt that that also worked well. And in phase 3, they tried to see the washout, and they compared children who were continued for 3 years. So this was this was one of the first studies where they continued it for 3 years, although a similar trial which we presented at AIUS in 2018, we presented our 3-year clinical data for the first time, but this was published, and they felt that it can be continued for 3 years at a stretch. This is the phase 3 LAMP report. And they also felt that rebound occurs definitely is higher with higher concentrations, and in some of the patients you may have to restart the treatment if there is enough rebound. And then this is the latest report, the 5-year clinical trial of low concentration atropine, where they felt that at least for a 5-year period there were patients in whom they had to restart the treatment, and also it is safe for 5 years. So longer treatment is what is now being pushed at. Higher concentration is now being pushed at. So there are two important key messages from phase 1, 2, 3, and 4 reports of LAMP studies. Now they also did tell that it was the younger age was associated with not poor treatment response to atropine, and the fact that it does not alter any other biometric changes. So they felt that ACD and all the parameters of the eye remained same when used 0.01% atropine. So all this workup, where does it leads us to? It leads us to few of the definitive facts. There are atropine eye drops do reduce the progression of myopia. It is concentration dependent. The lowest concentration which does work at this point of time is 0.01%. So that does hold value. Yes, you can increase the concentration in non-responders. We have done our work. And we feel that you can increase the concentration in non-responders. This is not published. May respond if the patient is not responding to 0.01%. Yes, it may respond. So we did some of the work on 0.01%. We compared single versus twice a day usage. Twice a day usage was definitely better than single day usage. We did use it in non-responders. We tried to use it twice a day. I think this data is there with twice a day usage in non-responders. And then we also use 0.05% atropine, compared it to non-responders of 0.01%. So these are patients who were using 0.01% eye drops and were not responding to it, meaning they were progressing despite the fact that there was good compliance, and yet they were progressing further. This was published by us on pre-myopes. So atropine 0.01% does work on pre-myopes. Pre-myopes are children who truly don't have myopia, and they are at the threshold where they may get converted into myopia. Nowadays, more and more patients, we are diagnosing. We are trying to have more and more risk factor assessment and risk scores of pre-myopia, so that we can predict early which patients would or convert to myopia. And those are the patients who are losing out their hyperopic reserve very quickly may get converted into myopes. And in those patients where we are particularly sure that these are progressing, we have a history of axial elongation, can be put on 0.01% eye drops for prevention of axial myopic progression in pre-myopes. So this was another work which we did for 0.01% atropine to be used in post pediatric cataract patients, where we felt that they had huge myopic shift, and we did feel that changing rate of axial growth did change, and the rate of axial growth went down sharply after starting 0.01%. So all in all, we have used 0.01% in once a day, twice a day. We have used it in in children with post-op pediatric cataracts. So lot of work on 0.01%. And is it really safe to use low concentration atropine eye drops? The first study, Atom 1, used 1%. So that was for almost for 2 years. We did pattern ERG and found that there was no change, at least in adults. We did do some work on higher order abrasions, and we showed that there was no change at the end of 1 year. Allergy to atropine, at least in our personal, at our clinic, we did not have many patients. We may had 1 or 2 patients. There is a case report by Mihir on the fact that at least 3 patients did convert from esophoria to esotropia. So a word of caution that if you have a patient of strabismus, or if you have a patient in whom you have the patient has been operated for strabismus, you should use it being more cautious. Pupil size change, in our work we found it to be a very small change with 0.01%. So most of the work is on 0.01%. How and when to start low concentration atropine? Well, you document the progression. You record that the progression is actually axial. From whatever we have done in last few years, we found that twice works better than once, at least for 2 years. But yes, we do recommend that you can continue it for longer. There is no upper age, and keep looking for non-responders, and younger children and children with history of parental myopia could be non-responders. So despite all that, there are a lot of non-responders, and we have more lectures on what to do with non-responders. If you see, this LAMP study itself had around 30% non-responders to 0.05%, 48% for 0.025%, on almost 57%, 56.2% non-responders to 0.01%. So we'll see in more lectures to come what is to be done with non-responders to 0.01%. And that's all regarding atropine 0.01%. Thank you so much for the time.
Thank you, Jitender. He was supposed to join, or he would try to join sometime during this webinar, and we hope he will. Then we can take direct comments from him. He's really set the stage for discussing what is new right now, and really the reason why we are here, because 0.05 is now uh, commercially available, was approved by the Drug Regulatory Authority just a few months ago. And Entod, and we are actually really grateful to Entod because they've constantly been on the forefront of providing these options for us, both when 0.01 was something that they pursued and were among the pioneers in bringing it to us. And now, thankfully, there are a lot of companies, so the cost is low, availability is universal, and they have been the first ones to really push 0.05. They were the ones who've done the trial comparing 0.01 and 0.05, which was the regulatory trial that got them the approval. And like I said, I think we all, pediatric ophthalmologists and ophthalmologists in general, should be grateful for their contribution to pediatric ophthalmology. So I think we'll go on to the next talk, which is on 0.05 atropine. Is it the optimal dose for us, in India particularly, or those with dark iris? For that, I invite Dr. Rebecca from RP Center to speak on the topic.
Thank you, sir. Quite delighted to speak on this topic because I think this is, after a long time, we are having something fresh in the platter, and it's now becoming commercially available. I think it's all the more important that we all should be aware of the various indications and the adverse effects, or whatever literature is available about 0.05%. So is my screen visible?
Yeah, it is.
Yeah, so I think my job has already been done quite easy by Dr. Jitender Jethani's such a comprehensive talk on atropine, especially 0.01%. So keeping that information in mind, now we can go ahead with whatever is available about 0.05%, especially in Indian population. So this all, as I told you, has been discussed. We've known about these studies. We have been reading about them. So n number of studies. The most research therapy, I would say, until now, in myopia has been atropine. So starting from 1% to 0.01%, we have tried it all. And what I realized that most studies have in common, that there is a concentration or a dose-dependent response with topical atropine. So higher the efficacy, but at the same time, higher the side effects. So what we are trying by juggling between these concentrations is we are just trying to find that right concentration that gives us the best efficacy versus side effect ratio. So I think that's what the game is about. Until now, in the market, I would say the champion was only one as far as the drug therapy is concerned. That was 0.01%. And it was, enjoying all the limelight. But now we have new star in the block, in the market. And with 0.05% in the market, now will it gonna take away the limelight of 0.01%? Well, that only the future can unravel the mystery for us. Meanwhile, let's just concentrate on what's available about 0.05%. So LAMP, again, already been discussed in detail by Dr. Jethani. So this was the first study that actually evaluated the role of 0.05% and compared it with 0.02% and 0.01%. So what it showed in the various phases, that essentially 0.05% has shown the best efficacy. The side effects, yes, of course, 30% of the patients did need photochromatic glasses overall. However, they were tolerable. So there was no change in vision related quality of life. So over 5 years, they have given this longest, I think, data about the 0.05%. Over 5 years, they have shown pretty good efficacy with good tolerance. But remember that this is the Chinese population we are talking about. Now coming to Indian ethnicity. Now, this is one important regulatory trial that Dr. Rohit was just talking about. This was Entod sponsored, and this was the phase 3 double-blinded multicentric RCT that actually led to the approvals related to the drug that we have now, that it's available in the market. So it did a head-on comparison between 0.01 and 0.05% atropine in Indian population. And look at the data. So you see that both were pretty effective in controlling myopia progression. Now, if you look at the percentage-wise patients who showed very minimal or less than 0.5 diopters of myopia progression, that's almost 70% of the patients are taken care with 0.01%. 0.05% gives you an extra advantage. Around 83% of the patients are being managed. And also, we didn't see much of a significant change in pupil size, accommodation amplitude. So it was quite tolerable. There was no significant increase in side effects, and it was a 1-year study. But so we have an Indian study, we have a Chinese study, but remember that there is a basic difference in the ethnicity. So look at the incidence and prevalence in the Chinese population. It's already pretty high, almost reaching up to 80-90%. And what's important to understand is that the mean myopia progression, if you do the head-on comparisons of the placebo group of the eye atom study from India and LAMP study from China, both of these groups, just look at the mean myopia progression. So the placebo group in the LAMP study is showing a progression of minus 0.8. So that's already a rapid progression. So there, I think ethnically, they are a rapidly progressing cohort as compared to Indian population, where the mean progression varies around 0.3 to 0.4 in different studies. And of course, there is a subset of patients, even in Indian population, who are rapid progressors or who are non-responsive to 0.01% therapy, which Dr. Jethani was talking about. Now, again, you compare the percentage of these non-responders. Now, it varies from almost 30%. So I'm just concentrating on 0.01% group. So the non-responders to 0.01, if you see, it varies from almost 30% to 9% in Chinese population. But in Indian population, it varies from 0% to around 2.6%. So again, this percentage of non-responders and rapid progressors is also low in Indian population. And what's the reason for this? Mostly what has been found in most studies, including LAMP and even IATM, is that these non-responders are younger age patients and they have a higher baseline myopia. So keeping this in mind, we did try this 0.05% atropine in rapid progressive childhood myopia. So this was a study done from our center where we recruited patients who already had a baseline progression of more than 0.75 diopters a year. So they had a documented progression a year. So we had been following these patients for a year, and we saw that the progression more than 0.75 diopters a year, they were recruited. So the mean progression that these children had was around -1. So this was the progression that was just before a year before recruitment. And just 1 year after treatment with 0.05%, look at the drastic significant reduction in the myopia progression. So 0.05% does really work well, especially also in these cases who are non-responders, or I would say rapid progressors. So this was rapid progressors group. But also important to remember here is that 3 out of the 40 patients that were recruited in this trial, 3 still did not respond to 0.05% atropine. So I guess this subset, a very smaller subset, would be the patients who we should go for either optical interventions or combination therapy. So I think pretty short it was, because we have limited studies in 0.05% atropine. Well, conclusion, I would just say that 0.01% works really well in most Indian children. But for now, 0.05% we could definitely, in Indian children, especially indicated in case of rapid progression or patients who are non-responding to 0.01% atropine, because there's nothing which is called ideal concentration of topical atropine yet. We are all trying to hit the bullseye, but hopefully for Indian scenario, this is what works best. Probably future long-term studies will tell us that whether 0.05% is really giving us some long-term diopteric benefits over 0.01%. Thank you.
Thank you, Rebecca. Some excellent moves on the chessboard.
Thank you, sir.
We've had some great discussions on 0.01 and 0.05.
Yes.
I know there are a lot of points we would want to discuss, but I think we'll just complete Jaspreet's talk so that we have the practical understanding of where and how we can place these drops and experience till thus far on how to prescribe. So we'll just go on to the last talk, which is practical prescribing, how to use atropine in real life by Dr. Jaspreet Sukhija from PGI Chandigarh. Again, someone with a lot of experience in using these drops. So Jaspreet, looking forward to hear from you.
Okay. Share screen. So that's it. Yeah. Yeah. So can you hear me and see my screen?
Yes, we can, but we're seeing your conclusion slide.
No.
Okay, great. Yeah, now we are. Okay, great. Full screen, yes.
Basically, I am just stirring up some controversy in starting this, and definitely is going to be a lot of discussion by the time I end, because some of the views will be opposite to what has been discussed, and obviously with more literature coming up. So basically, no financial interest in any part of this presentation. So as we know, because there's no a lot of trials are being done with atropine, but we still don't know what mechanism it works with, and how it's being so effective with so many concentrations and so much literature, but we're still not able to know what is the exact mechanism, how it's helping the children reduce the myopia. So most common concentration has been discussed and researched is no doubt 0.01%, but of course we have trials of 0.025 and then higher concentrations up till 1%. So these are some of the concentrations which have been used for atropine in various studies. So if you see the RCT network here, this circle here denotes the number of participants. And if you see with 0.01, you can say the maximum number of participants as compared to other concentrations of atropine. So this thickness of the line denotes the number of trials that have been done. And again, if you see, it's the 0.01%. The maximum number of trials with case control studies is again with 0.01%. So evidence for the higher concentrations is much less, and there is a lot of work being done and has been done with the lower concentration atropine. So coming to some of the practical aspects, obviously these are evidence-based. Whom and when to treat? Well, we know when to start treatments. The evidence says it's 4 to 15 years, because less than 4 years, probably you would look more into some kind of a syndromic child or a congenital high myopia. So it's always what literature is saying is start from about 4 years of age, who are at least minus 0.5 diopters myopic and with a definite history of progression. So we are harping upon pre-myopia as well. Well, atropine is still not, we don't have evidence for atropine in pre-myopes. It's just lifestyle changes. So to start atropine, well, you need to document progression. And of course, usually about 0.5 diopters over the last 6 months. The installation, yes, we usually give it for once daily, unless we want to customize it, unless there's a progression after this. And after 6 months, the progression should slow significantly, should be less than minus 0.5 diopters per year. And evaluate these children 3 months after the treatment starts to ensure that they have no significant side effects. Modify the dosing and concentration as per response. So basically, the thing is that it's not a sacrosanct rule or something that this child is going to have an effect with the treatment what is described in literature. You have to customize the concentrate the amount, the dosing of the atropine based on the response. And yes, we have studies now where they say there is no harm in continuing for 5 years, but there are no guidelines on how to stop this treatment. So how to select ideal concentration? Well, this was before ideal concentration when there was just 0.01%. But now with so much research being done on higher concentration, it's all based on response, and its myopia is something which is unpredictable. You cannot predict that this child is going to progress one way and how the other child is going to progress is going to be a totally different way. So what general guidelines one needs to be what needs to take care is it should be effective in slowing the myopia progression. It should be well tolerated by the patient, meaning that the child should not have difficulty in doing near work, not much photophobia, no headaches. So this is very important. And the other thing is, of course, we need a lot of studies have been done without measuring the rebound myopia, because this is one thing we need to know when you stop the treatment, what is really going to happen. So it should have minimal rebound myopia on stopping treatment. Now, how to know if atropine is working? If prescribing atropine, well, in a real world scenario, you cannot tell them, okay, fine, it's going to stop it. You cannot promise them. Well, it can slow it down. We can measure it by seeing the change in the refraction and the axial length compare it to the research data. That's one of the important things, how you can counsel the parents. The child's age is the key factor in how fast their myopia could be expected to progress and in determining the success of treatment. And children with myopia show faster progression when they are younger as compared to older children, that is maybe above 10 years or 12 to 15 years. And studies have shown that children of East Asian ethnicity tend to progress faster than non-Asian children. So some of the things we have to keep in mind while we are prescribing atropine and while we discuss it with the parents. Now, some of the important trials with the atropine, as I said, the maximum work has been done with 0.01%. So you have studies from Singapore, Hong Kong, Europe, and then you have one from India as well. So a lot of work has been done with 0.01 atropine. Now, a lot of questions about it. Is there a dose response to atropine? Now, with the dose response, obviously, we will like to have more evidence, but whatever few trials have been done, the important one being the LAMP study, where they did show it was a dose-dependent effect compared to placebo. The axial elongation was much less with the higher concentration. So it was just 0.21 as compared to 0.05 using this concentration. And similarly was the myopia progression, which was, you can say, the maximum slowing was observed with the higher concentration. And they show that the 0.01, 0.05%, which is the higher strength, had good tolerance over 5 years. It should be continued for 5 years. They did not find any loss of accommodative amplitude, and the photopic mesopic pupil size was same across all the group. But rebound was something which needs to be measured. So if you see the spherical equivalent progression, the axial length elongation and photophobia, when they compared lower strength versus the higher strength, what they found was 0.05% was working better in terms of reducing spherical equivalent progression and axial elongation. But the photophobia, the side effects were much more in with the higher concentration. So this is something which you have to balance out when you're prescribing. So that's why I said it's not that one size fits all. You have to really customize the treatment for every child. And similarly, what happened with the atom to extended study was that what happened was that it was a 5-year study. So they used 0.01, 0.1, and 0.5. So they did not use 0.05. It was a 0.5, a much higher concentration for 2 years. And then year 3, they just stopped it abruptly. And in year 4, when they restarted they found that those who were initially on the low concentration had lowest overall refractive progression. So those who were on 0.01 had the lowest overall progression as compared to 0.05, who progressed much more. And they then found that maybe 0.01% is clinically more palatable. But the problem here is, what was happening is, remember, with all these concentrations, remember what's happening, they're stopping it abruptly. There is no tapering what they are doing. So an abrupt stoppage of a higher concentration versus an abrupt stoppage of a lower concentration. So does everybody respond to low dose atropine? Well, not all, as I was saying. Each child is different. The progression varies among children. So not all would respond to 0.01%. So in children under 10, around 0.25 to 0.5 diopters per year of progression represents a great treatment outcome. Well, in children over 10, a 0.5 diopters per year or more of progression likely represents a non-response to myopia control treatment. Rapid progression, yes, they were seen. That's more than 1 diopters was seen in 18% at 2 years, and by LAMP in the LAMP study about 28%. That's quite a lot. And here we had some reasonably good results which was published in BGO by Rohit. At 2 years after starting atropine, there was mild progression in 87.7, so fairly a good control. And there was a 17.4% reduction in the rapid progressors with 2 years of atropine therapy. So it was working quite well, the low dose. Well, who are these who don't really respond? These are the poor responders. As was discussed in one of the previous presentations, they are younger patients, they are high myopes, and maybe have risk factors like both parents being myopic. So one has to be careful here. But then if the child is not responding, what else can we do here? So coming to the practical aspects, basically, you evaluate the cycloplegic refraction and the binocular vision. There could be an accommodative lag and phorias, which could be with the combination of esophoria at near, or there could be a high lag. So these are associated with increased rates of myopia progression. The child could have high AC by ratio, again, could be a poor responder. Always check with cycloplegic refraction. You don't want to miss out on accommodative spasm. And yes, the other thing is the child might be fusing when you're checking him. Always check for exophorias, because these are the children who would fuse and accommodate and would be responding poorly to the interventions with atropine, what you're trying to improve upon. So coming to some of the latest studies, what we have with higher strength atropine. Of course, now that Antod has come out with this Myatro XL, which is 0.05%, it's really a game changer. And one of the recent study in IGO was by Rohit again. They studied 40 children and they found a significant reduction in myopia progression in the fast progressors. However, there was no correlation in the axial length and spherical equivalent progression. That's from the study. And the response to treatment was independent of the age at baseline, the baseline refractive error, the baseline rate of progression, the gender and family history. And the important thing is there are no side effects with using a higher concentration. So you're not having any side effects with a higher concentration as well. And this is one of the recent studies just published July. This was published on 7 July, where they compared 0.04%, of course, to orthokeratology and 0.01. But my concern here is the higher concentration, which has been used with the lower concentration. It was a 2-year trial, what they did. And what they found was the interesting part was the photophobia. Now, if you see the photophobia at the 3-month visit with the 0.01%, it is 17 out of 67 patients in the lower concentration. But if they go to 0.05, it's 37 out of 67. So almost 50%. But if you see what happens at the end of 2 years, with the lower concentration, it's just one child having, and with 0.04%, it's just 11 children out of the 37 who had them at the beginning. So what their analysis suggested was that 0.04% atropine was most effective in mild myopia. That is started earlier, but this advantage diminished in moderate myopia. And the age group was 8 to 15 years. So basically what they're trying to say is that if you start the atropine higher concentration at a younger age, probably it will have more effect, rather than when the child is older. When you find that 0.01% is not effective, the higher concentration also would not be that much effective because the axial length is naturally slowing down. So that is what they meant to, what they were trying to say is that you start using it at a younger age. Well, with so much at 0.01%, this was some of the published data by WHO. It was in 2015. So many studies have been done after that. What they tried to recommend was that obviously give a low dose for 2 years, see the response. If it's a good response, well, taper and stop after 2 years. Moderate response, continue for a further 1 to 2 years and then taper. And if they're poor responder, well, maybe consider something else. So that was a recommendation way back. Obviously, their guidelines were based on the ATOM studies and they were published in 2015, but a lot has changed after that. So what is the ideal concentration? Well, there is no ideal concentration when, as was rightly told by Rebecca. This is all based on, it's all customized. Of course, we don't use 1% because of the rebound myopia, which has been shown. Same with the 0.5 and 0.1%, but we are having 0.05 and 0.01%, which are really doing well. But obviously, we will require more evidence with 0.05% to know the rebound myopia, what is going on. And so till that time, probably, what's happening? Is it a dose-dependent effect? Well, with more evidence coming up with 0.05%, I would say that this is like an age-dependent effect of atropine. The younger the age, the higher concentrations are going to work much well as compared to what now the latest study in JAMA, what they have told is that maybe when the child is older, this higher concentration loses its effect. So it's really age-dependent. So what does this mean for my practice? Well, if you have inference from the LAMP study, 0.05% appears to work best to control axial elongation. In the first year, it really worked well, then the 0.025, which worked well, then 0.01%. In the second year, the moderate and the low strength were almost equal, but the 0.05 still worked better. And the third year, as the age increased, as the age of the child was more, probably they had the same effect. So this is what something important which are coming out from these few studies is that it's an age-dependent effect of atropine rather than the dose-dependent effect of atropine. So initiate 0.05% and decrease the strength if required rather than the opposite. So basically something like what you would do in steroids, where you give higher concentration and then start to decrease the concentration. But really you want that effect at that stage when the progression is the fastest. Rebound effect with atropine 0.05% was small in the LAMP studies because they had a washout period as well, and they found it clinically insignificant. While the moderate and the lower strength did not experience a rebound effect, this indicates that there is likely still value in some form of tapering before atropine cessation. So don't stop it abruptly. These trials all have stopped it abruptly, just stopping it and seeing what really goes on. So just try to taper it and see how really the child is responding, whether you're having a rebound or not. So I'd like to conclude here by saying, well, till now, 0.01%, you have a lot of studies. It's a well-researched drug for myopia control with known efficacy. Side effects are negligible, works well in the Asian population, as is shown by the multicentric trials and basically, and a lot of work done by Rohit as well. It's cost effective, no significant rebound. You may start with higher concentration now with recent evidence. We require more trials to basically study this effect and preferably taper the higher strength before stopping. Photophobia, no doubt, is a bothersome side effect with higher strength. Thank you for your patient hearing.
Thank you, Jaspreet. Excellently bringing together the important aspects of atropine treatment, as well as raising a couple of controversial issues, which I'm sure are going to now fill the time we have for discussion. So before we start, can I request the admin to give the Entod teaser? Because in the end, I think all of us get fagged out, and I think it'll be better if we have it now and be out of the way so that we can continue the discussion uninterrupted till the end. Admin, is that possible? So that we can, at the peak, thank Entod for the contribution towards management of childhood myopia, as well as supporting this webinar. And of course, a lot of pediatric ophthalmology related activities all over the country. Maybe they'll hear and when they come back. So in the meantime, we can just let's launch into discussion. So Vivek, Rishi, maybe, and it would be good if everybody, opens their video so that I know that you are there, so that, we can encourage you to answer and say something. So yes, Vivek.
Yeah, I think all the talks, they were amazing, and there were a lot of new learning. The first two comprehensive talks, they taught us,
Sir,
we are
can I
already.
share the Entod video also?
Yes, I think so. I think, yeah,
Go ahead.
that'll be good. And then we'll
Myopia is supposed to be the next pandemic that we are facing after COVID. Now, myopia is also called nearsightedness, और ये इसलिए हो रहा है क्योंकि increasing urbanization and increasing screen time. The ultimate goal of Entod Pharmaceuticals is to create a strong legacy of pharmaceutical research.
If the window of your house is bad, the suffering is in the room. So the nose is actually the window of the throat.
The use of anti-aging and anti-wrinkle injections is on the rise in India. So these days, people want to look the best version of themselves, they want to look younger, and for that they're willing to get themselves poked regularly. We want to lead the pharmaceutical industry from a volume-driven sector to a value-driven innovation ecosystem.
So thank you for that. Thank you, Entod, for the support. So yes, sorry, Vivek, we interrupted you in the middle.
Yeah, so I was just trying to, recap the first two talks. We had been, practicing the lifestyle modifications, and we learn, how important is the myopia progression and how it is, the impact in terms of the quality of life and, the economic burden. So apart from that, which, the Dr. Siddharth K. Sarwani, he has highlighted, probably we have still scope to look at, the nutrition being a very complex space, and as we understand, like malnourished children, they do have a less height versus, very well nourished, they have a growth of the body in terms of height. So probably a similar analog we can, correlate in terms of, the myopia related to, the nutritional habits or the quality of food that we do eat. Another interesting thing is, the near work and the kind of habit that the child develops. So like tilting the head has some contribution in terms of causing a more ciliary body contraction, smaller pupillary size, and probably trigger for the myopia growth. So I think we are learning over the years new risk factors and trying to how we can mitigate the myopia progression. And as the Dr. Jethani's talk that has been, he has published extensively. Your group has published extensively, and we learned that 0.01% works, pretty well as of now, and we all are quite excited with the Mitro XL that has come up with me. Yesterday I got that drop, and we'll look at that, how it is going to really change the practice, because we all know that this is a concentration dependent, and that's how we were using 2 times a dose. So we have very handy drops to use and see. In terms of what I am really looking forward, like how the photophobia and how the rebound effect it will we will face. So whether we will use what Dr. Jasprit was talking, like tapping it down, or otherwise, so that we will learn. So moderate myopes and little bit elder age group, how this 0.05 will work, that we have to look over a period of time. Thank you, Dr. Roy. Yeah.
Right, great. So again, stage set. Sumita, you want to say something?
I
Yeah.
just wanted to say whether it makes sense in younger children who do not have that much of near activity. I think it might be a good idea to start relatively younger children on a higher concentration, because they are more homebound, less reading, writing work. So on that front also, probably it makes sense, apart from whatever Dr. Jaspreet has said about rebound, they being more effective when they are younger. I think it might be more practical also to put a younger children on slightly higher concentration.
Yeah, but at the same time, I had a different thought process, like we know that it works in even 0.01 in younger. So what happens to this middle age? Probably here it doesn't work. So what happens with 0.05? That is also going to be interesting.
So
Because-
the other way to explain it is that point you in younger children you see far more rapid progression. So maybe again, so if they are rapid progressors, think of 0.05, and even in younger children, if they are not rapid progressors, maybe you could still stick to. So maybe the rate of progression still should define our choice, but yes, I think time will tell as we get more experience. Rishi, you wanted to say something? Yeah,
Am I audible?
yeah, please.
Okay. Actually, when something new comes into the market, as Dr. Rebecca had suggested, that there was only one grandmaster. So everybody welcomed him as a champion, but now we have another one. So, I mean, at least the things are changing rapidly from 0.01 to 0.05%. I would like to ask actually, as of now, where does 0.05% atropine fit into the clinical practice for a general practitioner? I mean, only for non-responders to 0.01%, or I mean, directly you can start for younger age group, myopia.
Maybe we'll ask our grandmaster, Dr. Jethani, who has just joined us. So,
No, I
Dr.
was
Jethani.
there. No, so
Okay.
actually, I have a slightly different view. We have been using this drop Myotro XL since last 2.5 years, and I think what will happen, and obviously this may change, but I think what will happen is that maybe 0.05% would become the baseline treatment, because see, even if you see 0.01%, the LAMP trial, 50% of them don't respond to those patients. So why not make a strategy that we can start on 0.05%, and as Dr. Sumita said, that, if the patient has photophobia or has complaints of near vision, you can switch over to 0.01%. Because whatever we have seen in last 2.5 years, I think we had around 8 to 10% of children saying that they cannot tolerate 0.05, and when we started them on 0.01, they were able to tolerate it. So I think that is also another way of looking at it, that you can start it as a first line, because every parent wants to ask you whether this drop is going to stop the progression completely. And at this point of time, we just tell them that no, this is not like this. It is going to slow down the progression. So why not treat it with whatever best we have, and then keep 0.01 if they don't tolerate 0.05. That is another part of the story.
Yeah, Dr. Rushikesh, I just wanted to add, like if you look at the Dr. Rohit study, so it's kind of, the independent of, the baseline rate of progression. So I think that is the crux of the entire study of using, 0.05. So I think if we take that as a take home from that study, and as Dr. Jethani is saying, okay, even at the beginning, if we start, probably we don't need to worry whether the patient was, kind of a progressor or a non-progressor. And even if he is a non-progression, we are using higher concentration. We can always think about looking at other multiple aspects, like we can taper it, or we can move on to, the lower concentration.
Thank you. I just one more question before for non-responders, currently we are using 0.01% atropine at bedtime. So comparing twice application of atropine 0.01% versus once application of 0.05%, what will be more preferable for a non-responder?
So I would say, based on the fact that sheer clinical trials are available of 0.05 and we know the effect, I would rather shift, especially now that 0.05 is commercially available, shift to 0.05. I think 0.01 BD may be again a little higher effect than 0.01 OD. And because finally a chronic drug achieves a threshold state, which is the actual responsible for the effect. So 0.01 would have a particular continuous threshold effect, and 0.01 BD is going to be a little higher. So it's going to be definitely a little more effective, but we don't know how much. So the fact that it is commercially available and there is adequate research available in 0.05, I would say that the ease is on shifting to 0.05. And you can think of 0.01 BD or different dose schedules if there is a tolerance issue with 0.05. So that's one. Dr. Madhav had put a question in chat that one of his patients, I think, had photophobia post 0.01. And he wanted to know the experience or anything like this with any other patient which you have experienced. So anybody had photophobia with 0.01
No,
or significant adverse events?
I never had experience.
I never had photophobia. All my patients have tolerated 0.01.
No, I have about 90 odd cases on my list, but then only one had this problem. He was in 9th standard. So I believe that what he was telling was correct. And I have confirmed that it was not 1% atropine. That was my first question, whether he has received it wrongly as a 1% atropine. But it was only the mitro that he was using.
Okay.
So that's the only question. That otherwise, I am as of now using 0.01% only.
Sure, yeah. I think just an erratic response somewhere. We haven't had an experience. In fact, I had one patient who was using 1%. So that is why who accidentally got 1%. Those were in the early days when 0.01 was not so commonly used.
I shifted him on to homatropine. I know that but then unfortunately that patient got lost to the follow-up because his parent got transferred out of my place. So I have subsequently lost. So do you have anyone has got any experience with homatropine twice a day?
No experience with homatropine, but photophobia, normally when if the child keeps on putting, within a week, it becomes better. I don't know how long that particular patient had put. We had 3 patients of photophobia. Eventually, 2 of them got better, and one we had to stop atropine because patient was not able to tolerate.
Okay, that's fine.
So great. So anybody else with now experience? Yeah, Dr. Prasad, before we go around. Yeah, Dr. Prasad, tell me, your comments.
Absolutely. There is no reporting of any photophobia for any of my atropine 0.01% or 0.05%. Just one more question. One of the neglected topic is the rebound effect after 2 years or maybe after 5 years. So as we have the amblyopia treatment study 2C, in which they recommend the gradual tapering of amblyopia. So similarly, Jasprit also mentioned about the gradual tapering with as far as dosage is concerned. But are there any studies or are there any recommendations or are there any studies planned to see, the alternate night or maybe once a week gradual tapering vis-a-vis abrupt stoppage? So your take on it.
So WHO had recommended, as Jaspreet had pointed out pretty long time ago. We have a study which is still under review and for print, where we had tapered and stopped and compared to an abrupt stop, and we have found that the rebound was less with tapered and stopped 1 year after the last drop of atropine. As a clinical practice, we always taper and stop. Again, we used, as you mentioned or suggested, we went alternate day, then twice a week, and then once a week and stop. This was just our arbitrary tapering schedule, and there does not exist any clear defined tapering schedule. So we don't know the ideal tapering schedule. We experienced in our study a definitely lower rebound with tapered and stop as compared to sudden stop. So anybody
So
else?
tapering over how many months or something?
So it was for 1 month alternate day, then 1 month twice a week, and 1 month once a week. So it was a 3-month tapering schedule that we followed as compared to an abrupt stop. And then we followed up the final rebound at 1 year, which was greater in the sudden stop versus the tapered stop. So this was, like I said, just an arbitrary schedule that we picked up. Anybody else has any experience? Ramesh, Vivek? Yeah,
Yes.
Niluparna.
So
Yes.
we had also conducted one study where we studied the OCT thickness in these children and the axial length, where we had stopped the atropine or tapered it over a period of 6 months, and then we just completed the study, and hopefully we'll come up with that results soon. And we felt that the rebound was always less in these children, but we did not have a control group where we stopped abruptly. So this was purely on the OCT and the axial length based study. So
So the refractive error after 1 year after stopping compared
Yes.
to any historical data or any comparative data you could probably see. Of course, that's not a good comparison, but maybe your own historical data if you have of a rebound of your group. Like I said, it's not a truly randomized or truly comparative data, but because age and a lot of
Yes.
things can make a difference. But it would be interesting to know, and that's a very interesting work. We look forward to that.
So I have a question here actually. As we are talking about 0.05 years, starting even in younger age groups, especially 5 to 6 years, who present with a higher myopia, would you suggest, like, I just wanted to know for practical purposes, should we use a combination of optical with pharmacological first and then shift to 0.05, or should we start directly with 0.05 without a combination of optical and pharma drops?
So I'll tell you my experience in our pattern, and then we'll probably go around. It's an interesting question we'll take from others on the group. So I even now start with 0.01 if it's not a rapid progressor. If it's an average progressor, 0.5 to 0.75, we'll start with 0.01. Follow up the child at 6 months, see the rate of reduction in progression. If there is a moderate impact, it means that the drug is effective, but probably the dose is less. We shift to 0.05. If there is very poor response, I discuss with them that they could consider shifting to the optical, and I would encourage a shift to the optical so that we have a different style, a different thing altogether. And rapid progressors, we start with 0.05, and if still it continues to be rapidly progressing, we'll add the combination. So that's the kind of practice we do, or we are kind of working with. But we can go around and see, take a couple of opinions, and then Sumita, I think, had a comment to make. So Sumita, maybe you can comment on this and anything else you wanted to say.
Yes, ma'am. Yes. Thank you, sir.
For younger children, I usually try to talk to parents into glasses because it is a non-interventional intervention that in strict sense. Of
Should
course,
call
there are
that. I mean, you're undermining your own action that you're taking.
no, but younger children, I really seriously try to say ki we start with glasses. So that's my first option. But yes, if they are not affording or not willing, then yeah, 0.01%. And since we did not have access to any 0.05 and did not want to take consent for non off-label use, so I did not have no personal experience with 0.05. We did try 0.02 two times, and I think that has worked quite well in those children who did not respond or who
0.01 twice, BD.
twice. Yeah, that I
Great.
have some experience that we did work with that, but yeah, I didn't have access to 0.05. I had access, but I did not want to do the paperwork required for 0.05. So
Okay.
I think
Ramesh.
sitting in RP center
I
has
want-
its own.
Yeah.
Yeah,
Yeah,
Ramesh.
I think that we are talking about two different groups of patients. One
Mm.
is the new patient who come to us. Even in them, there are young patients, as Sumita is saying, 3-year-old coming to you with the high risk factors. Parents both are myopic, -5, -6. And there is a 3-year-old coming to you with 0.5, where I am not really worried. So I would not really start anything for the 6 months or 8 months or whatever. But if something has to be started for a 3-year-old or 4-year-old, I would start the glasses too, because it's easier, because they just have to give that. Obviously, they should not have any strabismus or any other things, which is a confounding factor. So when a new patient comes, we always do the risk assessment. Is this child is going to be, Rebecca has really said very nicely, higher the dose, it's efficacious, and more the rebound phenomenon. If you look at the 5 or 6 years growth or the course of the child, for a rapid progressor or a moderate risk and high risk, now it is available. 0.05, I would straight away start that. It was not a choice for me unless we used to do a pharmacological compounding and then used to give. Now it is, that's why in every country, availability of the options becomes very important. So in a high risk progressors, I would really start on higher dose, but still I have a lot of space for 0.01% to continue because it's a mild dose, long-term usage, very less rebound phenomenon. Having said that, if a new patient comes with already 0.01%, they're again progressing mildly, they're again progressing moderately and severe. Again, in severe, I will really switch into 0.05%, or the child's age is a little bit older. I think who asked, Rishikesh asked, I think I will combine another modality. And the last thing, elephant in the room, if they have a peripheral refraction as one of the risk factors, I would probably go into the more of an optical treatment as a combined strategy. And if the child is really old, 10 or 11 or 12 years, where you can treat myopia as well as I would go into orthokeratology for that. So this is the route I take in most of the patients, new patients or old patients, and high risk assessment is the most important. That's all I had.
don't know, even if they are high risk factors, without noting their progression in 6 months, what are you going to lose? Why start it in
I
the
would
first
not.
visit?
The baseline for me to start anything is 6 months.
No, you were saying first time coming.
I
First time
no,
coming.
I mean,
No.
I think it is, it's very clear. I think all of us are on the same page on that. Please
Yes.
document progression.
Yes.
First time a child comes and is diagnosed as myopia, irrespective of the magnitude of the myopia of the child, please confirm progression. In 6 months, nothing great is going to happen. He may be even a rapid progressor, means 0.75 diopters a year. He would have progressed by 3.5, 3.75, 0.3 diopters or zero point 0.4 diopters in that 6 months of follow. But you would know his rate of progression. You know he's a progressor. He requires treatment for that. And you will know his rate of progression so that you can judge as we are talking, because of the multiple options that are available. You can have your pick as to what would be the best treatment for that. So there is no one one treatment fits all kind of a thing. Yes,
Only
Sumit.
there is a little, because there is awareness about these interventions, I think there is immense amount of pressure from parents who don't want to do any lifestyle management and want the intervention straight away.
They
That's
think
yeah,
this
they
drugs
think
are
I
an
don't know
immunity.
about these glasses and they will
No.
They think this is an immunity to behavioral change.
behavioral,
I
exactly.
think
Yeah.
documentation of progression and behavioral change becomes a topmost compared to
Topmost
anything.
priority. Exactly.
I mean,
But yeah, nowadays
ev-
I can withstand that pressure because I'm sitting in a big institute, but a private practitioner's
I
one
guess,
who is
yeah.
clinic, I'm sure Siddharth has that immense pressure to start something in the first visit. So
Yes, Siddharth, you are now under the scanner on your practice. Unmute, unmute.
Myopia is high, I think.
Later. But I was waiting for 0.05% precisely for one reason, which I always felt. There is a lag between the time that you start 0.01% and the time you start getting the effect. Even in attempt to trials, you see that in the first 6 months of 0.01%, there was a continuous increase in progression. Only after 1 year did you start seeing that the graph started going down. So I always believe that because of this lag, there is probably a case for having something called as the loading dose. You start with a higher concentration for say a 3 months or something, and then you go to 0.01%. So that lag, you are not subjecting the child to a 1 year lag before the effect or the meaningful effect of low dose atropine kicks in. And that's why we used to always define non-progressors at the end of 1 year and not at the end of 6 months, because from there is this lag. So I think probably everybody's having a different opinion about this. Like Jitendra said that he would like to titrate it downwards, while somebody would like to titrate it upwards. What I feel is the answer is somewhere in the middle, where you will have to probably give a loading dose, stop the thing in its tracks, and then kind of titrate it downwards and see which is the best, lowest drug that you can give. Because a long-term drug, it's always better to give the lowest concentration possible, so that any of all of the unknown side effects over 25-30 year period would not manifest. So that is my take on it. As far as the pressure situation is concerned, my interaction with patient is so brief that I never feel any pressure. The approximate time that I spend with a patient is less than 2 minutes. That's hardly to feel any pressure whatsoever.
how you are able to finish a consultation in 2 minutes? I want to get a
He's
tutorial.
very quick. He has got a huge load, madam. He has got a huge load.
Even if it's a huge load, then also I want to get the tutorial on
Yeah,
that.
absolutely. Yeah, I mean, we struggle with our OPDs,
Exactly.
and I would love to know how I
Next
can turn
CME is
around
on
in 2 minutes.
Siddharth's practice, how to finish it in 2 minutes.
For
But
every situation.
the next webinar will be a live feed from Siddharth's clinic. So yeah, any comments around? Yeah, Prasad. Yeah, Dr. Prasad, please tell me.
Yeah, of course, I echo the remarks by Dr. Ramesh. But even before documentation, if the patient comes for the first time, and even if before there is a documentation of progression, in case of high risk patients like say younger age, both parents myopic, I would advocate very strongly the behavioral modifications first, even before the starting the treatment. That's one point I just wanted to mention.
Absolutely. I think a very, very important point. I think no discussion on myopia, childhood myopia should be without a discussion on lifestyle changes, the importance of insisting, really teaching the parents and the children about lifestyle change over the last 30 to 40 years, really responsible for the global epidemic in myopia. Because that's the one thing that has changed. And in 40, 50 years, genetics of the population of the world has not changed. So clearly, it's the environmental influence on our next generations that is responsible for the progression. Yes, we do have, I think, a few more minutes. So, any more comments around? Yeah, Rishikesh.
Actually, lifestyle modification recently in the myopia session of APAO, Dr. Ken Nischal had very well put it that if you are treating like a diabetic patient and treating him with medicine without any change in his diet and exercise, the medicines are not going to work. That is how I counsel my patients these days, that in addition to low dose atropine or the multiple segment glasses, if they don't change their lifestyle, my treatment perhaps is not going to work. That's my take, or that way I counsel my patients nowadays.
Absolutely, I agree. Yes. So any more comments before we kind of close it? We are closing in on to our deadline. So Dr. Shreya, you'll have to unmute if you want to say something. Yes.
Yeah. I just wanted to ask you, Dr. Rohit sir. Dr. Siddharth said all the studies and everything very well. And Dr. Siddharth also said, I agree with his point that can it be a loading dose and then tapering. I was just talking about the study, if any study available for non-school going rural children versus school going rural children. So that really says about lifestyle modification. In nowadays, it's very it's not easy to get non-school going children, but the place where I'm working with, there still we get few non-school going children because of the social circumstances. So if some studies available, or can we do some study for that?
So, I mean, I'll just tell you because we recently came across this problem because we did this survey in school in a fairly rural place where recruitments was over 90%. But our testing or, accessing children was somewhere between 60 to 70%. So almost 20 to 30% children in that school, and we went there every day for 1 week, were enrolled, but we were having no access to them properly because they were not coming. So in India, that is a problem, that enrollments are 90+% all over, but children either just come for the midday meal and go home, or maybe don't just turn up at all. Which is, I think, in the beginning also we were talking about the difference between the school-based and the community-based data that is coming. So I think obviously ideal would be a community-based survey, some of which are actually planned and are going to happen, vis-a-vis a school-based
We are also
survey,
doing
which is
now this.
very simple. Sorry?
True. That's what I was
Right.
saying. We are
Yeah.
planning to do that non-school going versus school going in rural area.
So
Thank
that
you
would
so
be an interesting thing. Parikshit, any experience with being able to catch children who are not actually attending school, may not be enrolled? Parikshit, something with your audio. Could you just on and off it again? We couldn't get your audio. Yeah. Parikshit, it's still a struggle.
he must be having that data, so we would like to hear from
Yeah,
him.
I guess yes, Parikshit is moving into a probably better. Uh, yeah. Parikshit still not there. You can turn off your video. Maybe that data feed will be adequate for the audio. Anyway, he's kind of scratched. So anybody else, anything on obviously, as I mentioned, there is an issue on enrollment versus actual attendance. So that is an experience we got when we tried our surveys, and we are ongoing with another survey. So that's the recent, which was in a rural area where we experienced this. So we're trying to see how we can access those children.
It will look so bad on our.
Absolutely.
If you publish it, it's a very
No, we are not planning to publish that.
But we
The
cannot.
challenge was to
We
access
have to
those
access
children who
data.
were not enrolled. So I mean, it's not nothing to do with finding out that, but we were looking at
No,
60,
just a
70%
side.
access. Yeah,
Yeah.
I know. It was a pretty much of a shock to me, and it's not very far in the rural, so a bit on the outskirts of Delhi.
I know what Shreya is talking about, but there are
That's what I was saying. Yeah,
Yeah, it is unfortunate.
Sumita is absolutely right. We cannot publish, but right? If we
At least we should know.
Yeah, I mean, we need to plan for that. We need to kind of. Yes, Parikshit, and can we get to hear you? I think he may have a challenge with his data. So,
I just want to
uh,
share one
yeah,
nice cartoon which has come from Dr. Ram Prakash about lifestyle changes. Can I share?
yeah, please, sure.
So this is about lifestyle management.
Ah, yeah. I remember seeing it in one of his presentations. Of
So you
course.
can see. So there goes our lifestyle.
Absolutely. That's true. I think it's true for all of us. Why should we expect something from parents when we ourselves are
Yeah.
shifted to heavily sedentary, heavily indoor, heavily dependent upon our tabs, phones, and everything. So it's the children learn from us. So unless we as adults actually change our behavioral patterns, I think we will always need the support of the pharmaceutical companies like Entor to make an impact on our population and our children. So I think that sums up what is the truth about myopia management. Lifestyle is great but difficult to follow. Easy to advise, but very, very difficult to probably comply with. So we are stuck with an increasing array of options that are coming up. And again, thank you to Entor for not only supporting pediatric ophthalmology, helping in research and bringing in newer molecules, but also helping in webinars like this, which help to disseminate education. A big thanks to AIOS that has given us the platform to reach out to everybody. Thanks to Dr. Santosh, Dr. Partha, the entire GC, Dr. Namrata, all of whom were very, very keen to participate. But I think there is some big event going somewhere, so they could not come. But thank you for giving us the opportunity and the platform. Thanks to our wonderful speakers and the excellent panel discussion that we were able to have. It was really very nice and enjoyable. And again, these periodic discussions help to highlight this major epidemic that is already upon us, and all we can do to prevent progressive myopia in the next generation. So thank you, everybody. Thank you very much for a wonderful session. Have a good day.
Thank you.
Thank you, sir.
Thank you.